things like that kind of stuff. They still want to outsource it to other sites, and they're not going to buy a whole equipment for one site.
Eli,
They're going to get so much money.
start.
I would love to have a marker in my hand, but I don't know where it's What's your question?
The pizzas were supposed to come here at 8 o'clock, but they came at 7:30, so I didn't want them to be cold.
Okay.
That's why.
Very good decision.
It's just such a good piece of power.
It's like Kathmandu.
Right.
Yeah.
Re-engineer.
It's like totally
Hey,
got
Sherpa.
How do you use this? Is it? Ah, here it is, okay. Alright. I'm Cecilia Burns. I'm just gonna start talking with you, but I want to get this out of the way.
Go ahead.
And I was the only one who brought a notebook to the session.
Alright.
Okay, so the question was, how should providers deal with different ACO quality measures from different payers? The question was, how to use technology to enable doctors, clinicians, to move from episodic care to population care. Thank you, Bob. Yeah. So essentially, I think part of this exercise is a little interesting, is that we all come from different backgrounds, but we seem to speak almost the same language, and it took a little time to kind of figure out our bearings, who was from where and what kind of information we could share. So as one of our group members pointed out, a lot of our dialogue involved anecdotal stories. It wasn't so much about data. So it was a conversation that flowed, but it flowed in a lot of different areas. And I'm just going to mention what those areas were. It started out with the fact that we're talking about concept of information gaps. With regard to that, we meant communication gaps or even cultural gaps, issues that could come up that are not necessarily documented in an episode of care, and they're happening outside the office. And the patient is not necessarily giving the provider the information they need in order to have an actionable item to help them improve their care. Is that correct what I'm saying here? Okay. I'm kind of doing that. The other concept that Susan mentioned in particular was that human behavior is unpredictable, especially in patients who are frequent flyers, repeat visitors, however you want to call it. So what we're thinking of is more to focus on the 80% and not the 20%. And how do we focus on that so that you have the measures that are coming in from the ACOs, you have the CMS measures. Different populations are going to have different measures based on their demographics, their age, or even their gender. And then we jumped, where did we jump to? Okay. We jumped to the concept that in order to get the patients to care, the concept of patient empowerment and understanding when the patient needs to come in, or if the patient needs to come in, that there's a place they can go and get immediate attention, not necessarily urgent care, but it's kind of Susan, is it what you were saying, the summary? You could go to like a clinic or an urgent care.
Or in something that doesn't exist today, which is an imagined location in a clinical practice where a patient who may be wondering at the early stages of illness or wellness still,
yes,
but wondering what their risk potential is. And right now, since we don't pay for that, there's no model for the providers to engage in that moment. So creating a new opportunity within a provider environment that's embraced rather than...
So that's even before the experience of having the medical home model, getting to before that point, where you're saying you have, I have my blood pressure going up and it's been 148 over 90 for 5 days in a row, and that seems really odd. Why am I not going to my physician to see that? And then you go to the physician and it's normal. So how do you catch that? And how does the patient feel that they can actually go to the physician and be like, yes, I need some care, but what's the next step? Is that what you're kind of bringing up, I think?
Yeah, and the other intersection of that in light of a patient who may have a familial history of risk factors that are still far away, but they may be the 30-year-old person who has parents who have hypertension or cancer, and so they're early in their life and they're starting to take better care of themselves and map their average situation, but now they want to understand that in relationship to their family risks or their environmental risks or their work stress risks, not waiting until they're actually so ill that they have a crash and burn, but have a new space in a clinical environment where a patient gets to raise their hand earlier and not have to wait for a payer model, because it's not going to happen.
Great that you mentioned payer model, because we discussed reimbursement models as well as the disincentive by having higher deductibles for health insurance to patients actually go visit the doctor. If your health insurance deductible is $2,000 or $4,000 a year, what's the likelihood that you're going to go in addition to your animal care visit for not feeling well for 7 days, thinking it's the flu, or you're going to actually go and see the physician and be like, well, I could have given you Tamiflu 3 days ago, but now you're at the tail end of the contagion of the process, so, then you're like, well, why did I come? So that you don't show up. So that was kind of the other concept that we brought up. We also discussed inconsistent second opinions, which is another thing that Susan mentioned. Okay, maybe I don't need to go to that one. Concept of personalized medicine, which is, in my opinion, a sliver of this whole conversation, because personalized medicine and advanced genomics and that kind of, it's, one person in our group knows a lot about this, but as I was discussing with someone out of the group, outcomes are not being correlated to genomics, and this was something that's not been done yet. What else did we talk about? We talked about surgeons. Quality of quality of care versus quality of personality. Well, the idea is that if you're going to go and you're going to go see a surgeon, I have a friend who's going to be a hip replacement, and she's already going for all her post-ops, and she's 31. Anyway, long story. But are you going to go for the one who's actually paying attention to you, listening to you, feeling trustworthy, or are you going to look at their metrics, if you're even allowed to look at their metrics of their successful surgeries and, shorter recovery time, no readmissions for, double knee replacement or hip replacements, or no complications when 30-day period, 60-day period, 90-day period. And how do you evaluate that? And there are hospitals that are already doing that, but it's not fully being done. And then, as a final, toward the end of the discussion, we're discussing quality indicators. Are the metrics really quality indicators, and what are the characteristics of those? Are the metrics actually telling the story, so to speak, of the real quality of the care that's being given, and the value of, consistency of measuring, and then the concept of having educational track for physicians to consider every decision has an economic impact. I believe that's it. We did jump around a lot.
Hold on right there.
Yeah.
Do you have any limiting steps in your discussion you want to ask to the group?
That's the wrong person.
So can you describe what you mean by that? Limiting.
If they were stuck somewhere the group couldn't solve, there's more people here who can help them out.
I think what our discussion was is towards the end of the conversation is that we didn't have necessarily in my opinion, a defined glossary or a starting point from where we're all coming from, and understanding exactly what everything is. I think that's part of it. When you're trying to do kind of brainstorming, you have to start kind of in the same area, but it's not always the same levels of experience. So like I haven't done ACO measures, but I've done some CM measures work, so I understand a bit of what that is and what goes into it. I've done laboratory length matching code stuff, that sort of thing. But I've not done reimbursement and payer models. So there might be some things that were discussed that were completely over my head that were.
But I think the answer to your question, Cal, is that we really had more of a dialogue. It was a fascinating dialogue.
Yeah,
it was a lot of fun.
Yeah.
I probably missed some things on here.
I think you did a really good job capturing it.
Oh.
But I don't think we, at the end of the day, and Adam and tell me where I'm missing here, but I think we sort of started at Mars and went to Uranus and then Earth. But we had a nice discussion about the planets, but we didn't really come to any great conclusion about any of them.
So they're not going to solve the world tomorrow?
No. I think we need another 25 hours.
That was one of my suggestions, to have one of these kinds of sessions, is to have a possibly similar, my background is library information science and formerly IT, so have a similar starting point, different levels of experience to bring in the dialogue, but you need a lot more time.
Absolutely. This is just to initiate the conversation.
No, I think
All
it's
of you
great.
will be invited to the LinkedIn group, and you can continue the conversation. And I will also send everyone's email if none of you have any objections, so that you can collaborate and discuss further your ideas.
They
We're
wanna
gonna
get
have one
questions.
big conference at the end of the year, and we're all gonna be the panelists, right?
Yeah, there you go. Any questions from me?
And we'll all be the ones sitting up on the days and
Yeah.
telling everyone else how great we are.
We'll all be the panel.
Yeah,
Now, you talked about metrics, right?
yeah.
Is that possible? Is it publicly available?
I think a lot of the metrics are not publicly available. I remember when we were working with the clients, I seem to remember them being all internal.
For good reason.
For good
I mean,
rea-
right
yeah.
now in the ACO models, they're looking at changing provider behavior, so.
Right.
Yeah, so they're all freaking out.
Yeah,
But
there's a lot going on.
well, the other comment that when we're talking about metrics is the fact that a lot of them are presented to the public in a way that the public doesn't know how to interpret them. Where they're not used in a way that, somebody's mobility or mortality is, well, what's their acuity index? And are they, the best surgeons are treating the sicker patients, so can you really evaluate that more
Well,
people
how-
die for Dr. Jones and Dr. Smith?
And how true is that depending on the type of hospital you have?
Of course,
Community versus private,
There's,
that sort of
so
thing.
there's, I think, that was one of the questions that was had,
Yeah.
is how easy is those metrics to really evaluate anything?
Plus, people who have tried to do that are being threatened with lawsuits, so it's a little bit dicier business model, and immediately you're gonna release some kind of data, you're gonna get sued.
Yeah.
Other thing is, good quality can be a bad thing. So with CAP scores, you get score based on patient satisfaction. Well, if you're preventing patients from getting drugs that they really shouldn't be having, but they actively want, you're gonna get a lower CAP score. If you're a surgeon and you save a patient that's very marginal, and then they get readmitted, now you've got a higher readmission rate. And so hospitals and physicians that are low quality from the measures may actually be high quality from the standpoint of constructs that people actually care about.
Right.
And then the other piece that we tried to, why the conversation got a little perhaps circular or larger, was we tried to insert the patient experience in all of this. So at some point, when do you consider, with all of your designing a model and looking at data and the fact that there's an individual patient involved, and how do you create a system and an environment that's sensitive enough to incorporate the needs of that individual? And that's where I think it became a little large scoped, because that kind of cracks it open a little bit.
And I think what we started is how to change the behavior of the practice, especially the physician, with ACO metrics, with other things, and then we identified the patient issue, so that was the conflict. But great discussion.
Thank you. Who's next?
How many topics did we have?
It's not hard, it's not painful.
She's still breathing.
Took good notes.
Go ahead.
How many topics did we have?
3 or 4.
Thank
3 or 4.
And how much time do we have to present?
It doesn't matter.
I'm gonna help
But,
you out right there.
Yeah, you're gonna.
The secret is to be brief, be
I'm gonna be
witty,
brief.
and be seated. So,
Yeah, so I'm standing right here. You can just put the camera here. I'm not getting up there.
Sure.
our challenge
Wanna
was
be
patient
comfortable.
empowerment and shared decision-making, and we, like you, went down at least a dozen different tangents. Everyone has different experiences, different ideas, and we talked about a lot of things, but we wanted to crystallize it into 2 central themes that we thought would help in terms of patient empowerment. One is patient-centered medical home, which with the 2011 guidelines is very strong with patient engagement and patient experience. So we were really happy about those 2 pieces helping with a patient-centered medical home. You can't do ACOs without patient medical homes. A lot of people can be doing ACOs until they figure out whether or not they're going to work. And then the other area that we said has to change in order to make patient empowerment available and work is reimbursement. And we're starting to see a little bit of changes there. Instead of the old fee-for-service model where you get reimbursed on volume, that you get reimbursed based on outcomes, and that we start allowing for payment for some of these more modern things, like what technology can do. So that was it. We solved it with patient-centered medical home we did embed a few clinical pharmacists because we had someone here who knows a lot about that, and I know a project in Pennsylvania that's doing it. So, and then the reimbursement structure that has to change, and we need to see the providers change it. And we also did end our little conversation with a comment that Medicare, Centers for Medicare and Medicaid Innovation is probably doing more than we've ever seen in terms of really bringing modern ideas to our good old stodgy Medicare. So we have hope. So,
Fantastic. Does anyone have any comments or questions?
or other solutions besides our two quick and easy fixes? Because we wanted to do it fast.
The patient medical at home, what were some of the, you're discussing the logistical requirements with that, or are there actually existing models that you're thinking about?
The patient-centered medical home requirements for 2011 include patient engagement. They don't call it empowerment. I call it empowerment. Danny, you call it empowerment, right? We don't call it, but and patient experience, and so along with quality of care and all the other pieces. But the patient, and the other thing about patient-centered medical home, it's not just for sick people. It's to keep you well too. So, you know, it's the whole idea of, is it a sickness system or a wellness system, and so on. So.
I know, were there any actual models that came in mind that are ahead of the curve on getting that done?
Patient-centered medical home? There's tons of them across the country now. There was a lot that happened in the pediatrics, and you really can't have an ACO without patient-centered medical home. So you just can't do it. You've got to have that team taking care of the patient, whether they're sick or well. So anyway, sorry it was a short and sweet, but
thank you. Thank you, Pat. Who's next?
Okay.
Go ahead.
So our topic was changing models for revenues in hospitals, and some of the 3 areas of focus was retail and healthcare and pharmacy, and creating these new marketplaces, consumer and employee-driven engagement. And then we also had these ATM express prescriptions, and our team was Cheyenne and Baruch. And we came up with just the outcomes basically was for us to kind of understand what it all meant. And the question was, well, why would there be a retail and healthcare marketplace at a hospital as opposed to CVS's? And the thought process was, you know, it really comes down to patient and employee engagements and patient loyalty and brand, hospitals branding, changing the models. They're losing money in one area. They want to build these new revenue streams. So the thought process is, and Cheyenne was very good about saying, well, you go into a pharmacy and you buy a drug in the hospital because you're there. There's no revenue in that. It's out-of-pocket revenue. It's retail. And for example, we see a future model of children's hospitals, and the marketplace would be related to the children and the patients that are coming in and employees. A women's hospital, it could be, you know, a marketplace for women with bras. I mean, you know, these are the things that we're thinking of in regards to the future of the retail and healthcare and revenue streams. And so we looked at 3 areas. We looked at why would we be doing something like this, and it'd be the hospitals are competitive. They want more branding, they want more revenue stream, they want loyalty programs, maybe some reward programs in their marketplaces, and then they can go for a spa somewhere, and you know, keeping the integration of wellness instead of going to hospital and thinking of always being sick and a bill. You think of going to the hospital for you know, an engagement of a positive experience, and you guys can finalize my thoughts in any way. But so the question was, how is it going to be different in a pharmacy or marketplace in a hospital with a revenue stream as opposed to going to CVS? And that's kind of where we left off. Basically, we just want to make sure we understand that it's out there. There's a new vision for this, and you know, how we're creating that vision is still in the in a few more sessions. But it was just a passion that came through that we all kind of became very passionate about. And you guys can give any final thoughts you want.
So what he came up with is a very interesting idea of, you can actually have some form of incubator in the hospital. And one of the thoughts that came up was, in the food area, could you focus on healthy food alternatives being offered, or so that is, you're leasing the space, you're actually helping a small entrepreneur come up with nutritionally balanced, everything of that sort. So that was one of the thoughts that came out. The other thought was, if you were to take primary care out of a hospital setting, and if you were to have a group of primary care providers, now that becomes a less critical issue when people go in, and that could be more of a retail environment rather than in a hospital where, our limbic association with the hospital is somebody's going to die.
Right.
And in that circumstance, it's very difficult to have people come in and spend money or time or be attracted to walk through and get the foot traffic. So that is probably where this is going. Is you could get the additional revenue by integrating primary care offices with retail. And one of the thoughts that Paula was coming out with is the reward points.
Mm-hmm.
So the analogy is the grocery store tying up with a gas station.
Mm-hmm.
So, completely different model, but could you do that with healthcare? And, spas was one of the things that was mentioned, exercise places where you go, you spend something out of pocket, you get a benefit to go do something else, some other place.
Yeah, like the idea is kind of like health accessories. Like you were talking about the glass case. You buy a pair of glasses for $30, but then you have the other accessories you get with it.
Yeah.
Or like orthotics with flat feet, they're not covered by insurance. And so a lot of the big thing is too that since a lot of times doctors may prescribe exercise, you're not going to get a discount on the bicycle maybe, or you're not going to get a discount when they do. Then why not sell that on premises as well? But that was one other thing too, was the whole other costs that patients incur. That, and also for the people who are visiting patients, if they're hospitality, if they have to stay with their sick relatives, housing.
Keep it as more of a wellness, and hospitals have to be competitive, and they have to engage their patients and their employees.
Mm-hmm.
So their branding and their surveys and everything. So this is something I think is really coming on the cusp, and I think it has a lot more discussion that could be coming. And they call it retail and marketplace and healthcare, but it's really about branding and patient and consumer and patient engagement.
Blue
Sure.
There's a company a woman had a vision for that. She used to be on the board of directors for Partners Healthcare when this whole health thing first started off. And talk about a visionary. She was like 6 years out, 10 years out, but she has this vision. Pretty much what you're saying, and it also goes to an even extended level. She's built in, like, you have your own Whole Foods place there, to get like the right things that you need. It's like a community. And I think, it probably needs to be tweaked from where it is, from where she started it, but she at least had that vision, and that was like 3 years ago. So,
right.
And,
people are doing it.
And so she was targeting the Cape. It's a good community to go. Down there's a lot of folks that, we were talking earlier about what's the age that you consider, a senior citizen or retiring or whatever. And, people want a good quality of life still, and access to all good things, and there's more disposable income, and have that whole retail, thing work for you. So it's definitely a model.
So this is already happening. Henry Ford Hospital in Bloomington, Michigan, is a community destination, and it has got the restaurants and the cooking classes and the spas, and they've really made quite something. So their revenue stream from their for-profit end of the work that they do is considerable.
Right.
As community hospital.
But everything's mass produced.
So anyhow, it's just we're just throwing it out there. We're just throwing it out there, and wanted to just let you know that we're thinking of that line.
It's also being done in other countries,
right,
extensively, where the regulations are different, and so the choices are different.
Somebody was talking about you can have these little bunk bed hostels where you can just stay right there. And
the Japanese,
hotels.
Instead of sitting in chairs, it's just, just expanding the new vision of a hospital.
Whole building communities where pretty much your school, everything else is in one building complex, and so that almost, it reminds me of that a little bit.
I mean, India is coming up very big for something like this because most healthcare is out of pocket.
Really?
So when you go to the high-end retail market space, because it is all retail, because you're paying it out of pocket, those hospitals look and feel better than five-star hotels.
That's what they say. Yeah.
So, you know, I think the issue is reimbursement, which is going to kind of push everything down here.
Right.
If people are paying out of pocket, you have choice, you can walk across the street to a different hospital, right?
That's where medical tourism to India is really taking off.
It's taking off.
Yeah.
Anyhow, that's it.
Thank you, Paula.
You're welcome.
We talked about using healthcare data analytics to bring down the cost, the Medicaid cost. We could look at claims data. I don't know. We got stuck at what is the information we're going to look at the claims data to bring down the Medicaid cost. And I'm posing a question to all of you is what kind of things would we look at the claims data to bring down the Medicaid cost? Just by looking at the claims data. This kind of healthcare data analytics software would be used by the state. I'm not talking about using this software on the ACOs where there's electronic medical data available as well.
So
Go ahead, Andy.
Medicare has these things called RACs, which basically go through and analyze old Medicare claims data to try and ferret out fraud in a way to reduce cost. There are like 4 government contractors across the country that do this. Maybe some model like that on a smaller scale, or even integrating them with Medicaid claims, which would be kind of a nightmare, but fun anyway.
Okay. Alright, so just follow the...
The RAC, R-A-C.
Okay. Alright, thank you. Anyone?
Yes, I would do maybe predictive modeling on the DRGs for inpatient stays. For many DRGs, there's both a high and low severity version. High severity version is often assessed about 30% more money. If there are some patients that seem to be needlessly getting this, that's something to look into.
How would you determine, because the physician is putting them into the high-paying DRG or the low-paying DRG, and it is at the physician level that that decision is being made. Unless you go back and start looking at the, what are you going to look at? You're going to look at the previous claims history from that patient and correlate that to the severity?
No, frankly, I would go to the companies that are, their business is to maximize the coding and to see what algorithms they're using to maximize the coding and turn it around. Because there's a hell of an industry about maximizing coding.
Plus, there's a new job called CDI, Clinical Documentation Improvement Person. And people in my career field do this in hospitals. And I was very interested when I first heard it talked about, because you cannot suggest to a doctor, hey, I think you missed this, and what do you think? You have to be very careful about the way you word it, but you do have to review the record to see if there's anything that's been missed that would create greater reimbursement. So it's called CDI.
My company actually has a service that does kind of the reverse of this. We can determine which records likely have something missing. We don't know what, but we can say, look, take another look at these. These are probably fine, but these ones, have your doctors look at them again. And you can find statistical correlations in these things. So that's just a thought.
Sure.
Yeah, but you're looking at not just claims data when you're doing that, aren't you?
The claims data has the diagnostic codes, procedure codes, a lot of stuff. And then I also was looking at whole hospital. So I was looking also at relationships between activities in the hospital as well as within the home.
Is there anyone who wants to tell the topic, or is everyone done? Alright, I want to thank you so much. I just want to reiterate that I'm going to send the transcript of the whole discussion and share it with you. And I'm also going to send emails of all of you. If any one of you has an objection, please come talk to me. I'm going to omit their email. The whole point is that this is the starting of a discussion. I want you to continue this discussion, meet again, talk to people, and try to collaborate and take it to the next level. I want to thank you so much for coming, and I hope to see you in a month. Thank you, and have a good evening.
Okay.
Thanks. Thank you very much.